Hi everyone, my name is Dan and I'm a mental health pharmacist, and today I wanted to do a quick presentation about obsessive-compulsive disorder. So we're going to talk about what that makes this a disorder and differentiates it from people that just like things arranged in a particular way or just like things a certain way. So if you notice that R on this slide is a little off and that's bothering you, we're going to go more into that. Okay, so I have four major objectives. I want to go into the DSM-5 and talk about the diagnostic criteria for obsessive-compulsive disorder. I then want to go into the disease state a little further, talk about risk factors, neuroanatomy. Then I want to talk about treatments, both pharm and non-pharmacologic options, and then develop a treatment plan. My presentation will follow three major sections. First, we'll start with the background, talking about what is OCD. Then we'll go into the disease in a little more detail. And finally, we'll talk about treatment. So let's get started into the background. What is OCD? OCD is a long-lasting illness characterized by recurrent, uncontrollable thoughts, which are obsessions, or engaging in repetitive behaviors, which are compulsions, or both. These symptoms are time-consuming and they interfere with functioning. That's what makes this a disorder. So what are obsessions? These are intrusive, repeated thoughts or urges. A common one would be, for example, fear of germs or contamination. Another one would be forgetting to lock the door, thinking about that over and over, or leaving your oven on, or leaving your hair straightener on, something like that. It can also be fear of losing control, aggressive thoughts, unwanted taboo thoughts that are just intrusive into someone's mind. What are compulsions? So compulsions are actions directed at helping with the compulsions, with the obsessions. So for example, if the obsession is cleanliness, the compulsion might be excessive cleaning, whether it's washing hands or cleaning the house, something like that. If the obsession is on whether their house is locked, the compulsion might be to go home multiple times to check to make sure the door is still locked. Compulsions often correspond to obsessions. So like we said, if the fear is contamination, the compulsion might be washing hands. If the fear is concern about losing something, the compulsion might be to hoard and not throw away anything. So in the DSM-5 chapter for obsessive-compulsive and related disorders, some other disorders in this chapter, meaning related disorders, are things like body dysmorphic disorder, hoarding disorder, trichotillomania, which is hair pulling, and excoriation disorder, which is skin picking. The DSM-5 criteria can be seen here, and it's relatively straightforward. So it's the presence of obsessions, compulsions, or both. And it defines what an obsession and compulsion is, but it's similar to what we just went over. Another component is the time. So for this to be a disorder, there has to be a significant time investment. The DSM-5 specifies at least 1 hour per day. So people that like things organized a certain way don't necessarily have OCD unless if they're spending over an hour fixing how things are organized or arranged. Next is functioning is impaired. So that's what makes it a disorder. So people are missing work, missing school, not going to see the doctor because they're worried about contamination, all sorts of functional impairment like that. One of the most popular scales that's used is called the Yale-Brown Obsessive-Compulsive Scale, or YBOX for short. This is a pretty good scale. I provided a little bit of the examples of the questions about obsessions and a few questions about compulsions, but there's more questions in the scale than what I included on the slides. Here's the scoring. So this again puts an objective number to subjective symptoms and helps you to track how severe someone's OCD is over time. Response is defined as a 25% reduction in their score, but response isn't really the goal. Remission is the goal. You want someone to be able to function again. So remission is when the score is less than 8, which is subclinical amounts of OCD. So now let's go into the next section, which is the disease progression. So prevalence is just over 1%, so you will see it in practice, so it's good to know a little bit about it. Similar prevalence is found in other countries, so this isn't necessarily a cultural component. It's seen across the world at roughly this percentage. Women are more affected in adulthood, but men are more affected in childhood. Mean age of onset's 19. 25% of cases start by age 14. Onset after 35 can happen, but is quite unusual. Untreated OCD can be chronic, so 40% of individuals with OCD in childhood may experience remission, which means that 60% don't experience remission. Some environmental factors are related to the mother of the child, so premature birth, maternal smoking during pregnancy, can all impact OCD. Next is traumatic events during childhood increase the prevalence of OCD. There are genetic risks, like most mental health conditions, so some people are just genetically predisposed to be more likely to have obsessive-compulsive disorder. So there are functional consequences, so this reduces quality of life. There's functional impairment, and there are health consequences. So imagine someone's obsession is with cleanliness and their compulsion is washing their hands. I've seen patients with their hands dry, cracked, bleeding, really unhealthy skin due to the obsessions and compulsions. Some patients that are afraid of contamination won't go to doctor's offices because they think they're too dirty. So if they have diabetes or hypertension or something else, they're not getting those treated. Pathophysiology is not fully understood and has almost been reverse engineered at this point. So sometimes after people have a stroke or damage to certain areas of their brain, they'll develop OCD. And they found that this happens in the corticostriatal thalamocortical circuits. So a pretty complicated pathway, but it's not fully understood. Interestingly, there's a pediatric infectious disease process that can happen that causes an autoimmune response that can also cause OCD. This is called PANDAS. So now let's go into the treatment. Let's look at some treatment guidelines, and where you want to start is with exposure-based therapy, CBT, or SSRI medications. After you try one or two of the first-line options, the second-line option is generally an older antidepressant in the TCA class, tricyclic antidepressant called clomipramine. There are a few other options, and you might see for third line, they're considering augmenting with antipsychotics. Here are the SSRIs that are FDA approved for OCD, and a study below compared therapy to fluvoxamine, and it found that both did better than the control group, but the therapy group did a little bit better. That being said, the fluvoxamine in this study was not maximized in its dosing, and OCD-specific characteristics of SSRIs include high dosing. So often higher doses are needed to treat OCD. Next is duration. So we know that SSRIs take a long time to work in depression, anxiety, everything they're used for. And this is also the case for OCD. In fact, it's recommended to wait 12 weeks at an adequate dose before you determine if a medication is a treatment failure or not. So 3 whole months. So for tricyclic antidepressants, we have one that's used relatively commonly in OCD. This is called clomipramine. Clomipramine may be more effective than the SSRIs, but it's less tolerated. So that's why this is reserved for after first-line options have been tried and failed. You can see from this study on the right, this study was in pediatric patients, but it compared clomipramine to SSRIs, and the clomipramine decreased the Y-box scores more. So how I think about clomipramine are TCAs are kind of like really messy SNRIs. So they are serotonin reuptake inhibitors, norepinephrine reuptake inhibitors. But there's a phrase that something can be ham-handed or ham-fisted. It means like a clumsy attempt at something. So I think of these as ham-handed SNRIs. And the ham stands for histamine, alpha, and muscarinic. So TCAs block all 3 of these things. And this explains a lot of the side effects. So TCAs block histamine, so they're sedating. They can cause weight gain. They block alpha, so they can cause orthostasis, blood pressure changes, falls. and they're antimuscarinic, which means anticholinergic in this case, and it can cause constipation, dry mouth, blurred vision, those sorts of things. So TCA, this clomipramine, might be a little more effective than the SSRIs, but as you can see from the extensive side effects, it's less tolerated. Interestingly, you can sometimes see clomipramine added to SSRI treatment. They have relatively similar mechanisms, so it's not done too often, but it is an option. Also, if you remember from the guidelines, augmenting with antipsychotics seems to be a third-line option. So here's a trial where patients were treated as normal with SSRIs, and some they added quetiapine, which is an atypical antipsychotic, and some patients they added clomipramine to the treatment, and the quetiapine group seemed to do better. So a small percentage of patients that aren't fully responding may do well by adding an antipsychotic for their OCD treatment. There's some interesting other meds. I'm just going to cover one additional one that wasn't in the guidelines, and this is memantine. So memantine is an NMDA antagonist that's FDA approved for Alzheimer's dementia. And a few trials looked at this for OCD and seems to have a potential benefit. So there's maybe more treatments that you'll see added to the guidelines in the future for OCD. So I hope that was helpful in covering the objectives, and that's all I had for this presentation. Thank you for watching.